Assalamu alaikum. Now I would like to discuss a very high-level topic of poisoning and toxicity chapter, that is acetaminophen overuse. Acetaminophen and widely used name is paracetamol. First, I would like to discuss about the hepatic metabolism of acetaminophen. These acetaminophen these acetaminophen CYP cytochrome P450. Cytochrome P450 is 8% and sulfation and glucuronidation is 90%. So in acetaminophen, cytochrome P450 enzyme breakdown is only 8% and it is breakdown by this NAPQ, N-acetyl P-benzoquinine, N-acetyl P-benzoquinine, and sulfation and glucuronidation is about 90% sulfation and glucuronidation. It is non-toxic metabolites, non-toxic, which is excreted through non-toxic excreted through urine. And this NAPQ becomes NAPQ, unconjugated NAPQ, and causing hepatotoxicity. And in N-acetylcysteine there is an enzyme. If presence of N-acetylcysteine stimulates the glutathione, and glutathione actually uh, conjugates the NAPQ and excreted through the urine. So this is the hepatic metabolism of acetaminophen toxicity. Metabolism things are complex, but this is a very important topic. Like acetaminophen or overdose can happen in anybody because it is easily available. It is the over-the-counter drug. So we need to know about this mechanism of action and about the acetaminophen toxicity. So pathophysiology is depletion of intrahepatic glutathione, which actually conjugating the NAPQ. So depletion of intrahepatic glutathione, accumulation of NAPQ, toxic metabolites of acetaminophen, and thus causing the hepatotoxicity. Clinical feature from the time of ingestion less than 24 hours, less or equal 24 hours. There may be asymptomatic, no symptoms, no specific symptoms like nausea, vomiting, and fatigue. Okay, for 24 to 72 hours, there may be increased liver function test, AS, there may be increased ALT and AST. And for 72 to 96 hours, there may be ASTLT, maybe in a peak, maybe sometimes more than 10,000, maybe sometimes more than 10,000. And PTT is high, PTT is high, and there may be hypoglycemia, lactic acidosis, increased bilirubin, and acute kidney injury. And within 4 to 14 days, there may be recovery. Diagnosis is serum acetaminophen level 4 to 24-hour liver function test, B1 electrolyte. Treatment is activated charcoal if less than 4 hours, and an acetyl cysteine. Acetaminophen toxicity, we know that it's a medical emergency, can lead to hepatotoxicity and fulminant liver failure, and can cause fulminant liver failure. Okay, look at this flowchart. Very, very, very high end. Acetaminophen intoxication. Single dose, more than 7.5 gram. More than 7.5 gram. That is, in pediatric case, more than 150 milligram per kg. No, or intermediate chronic congestion. Yes, check acetaminophen level. If single dose more than 7.5 milligram, yes. Less than 4 hours of injection, yes. Activated charcoal, check the acetaminophen level. Check the acetaminophen level. Levels above treatment line in the normogram. This normogram is called Rumac Rumac Matthew Matthew normogram. The Rumac Matthew normogram levels above treatment line in normogram more than 10 microgram per ml. If timing of congestion is unclear, more than 10 microgram per ml. If timing of congestion is unclear, any evidence of liver injury, administer in acetylcysteine and monitor liver injury. So this normogram, Rumek Matthew normogram, which correlates the serum acetaminophen level obtained at least less than 4 hour after ingestion with the time of ingestion and is used to determine the risk of hepatotoxicity after a single overdose. Prompt treatment with the antidote and acetylcysteine is most important prevention for liver injury. So altered mental status is a condition. Altered mental status is a contraindication to charcoal due to risk of aspiration. If the patient has altered mental status, do not go for activated charcoal. So that is all about acetaminophen intoxication. This is a very high yield topic. Hope you enjoy.